Hemorrhoids, also called piles, are vascular structures in the anal canal. In their normal state, they are cushions that help with stool control. They become a disease when swollen or inflamed. The unqualified term hemorrhoid is often used to refer to the disease. The first known mention of the disease is from a 1700 BCE Egyptian papyrus. Signs and symptoms equals an external hemorrhoid. 1 in about 40% of people with pathological hemorrhoids there are no significant symptoms. Internal and external hemorrhoids may present differently, however, many people may have a combination of the two. 2. Bleeding enough to cause anemia is rare, and life-threatening bleeding is even more uncommon. 3. Many people feel embarrassed when facing the problem and often seek medical care only when the case is advanced. 4. If not thrombosed, external hemorrhoids may cause few problems. 5. When thrombosed, hemorrhoids may be very painful. Nevertheless, this pain typically resolves in 2 to 3 days. 6. The swelling may, however, take a few weeks to disappear. A skin tag may remain after healing. 7. If hemorrhoids are large and cause issues with hygiene, they may produce irritation of the surrounding skin, and thus itchiness around the anus. 2. Internal hemorrhoid signs and symptoms, equals internal hemorrhoids are usually painful only if they become thrombosed or necrotic. 1. Internal hemorrhoids usually present with painless, bright red rectal bleeding during or following a bowel movement. 2. The blood typically covers the stool, a condition known as hematochezia, is on the toilet paper, or drips into the toilet bowl. 3. The stool itself is usually normally colored. 4. Other symptoms may include mucus discharge. 5. A perianal mass if they prolapse through the anus. 6. Itchiness. 7. Fecal incontinence. Internal hemorrhoids are usually painful only if they become thrombosed or necrotic. 7. Fecal incontinence. Causes of hemorrhoid. The exact cause of symptomatic hemorrhoids is unknown. A number of factors are believed to play a role, including 1. Irregular bowel habits, constipation or diarrhea, 2. Lack of exercise, 3. Nutritional factors, low-fiber diets, 4. Increased intra-abdominal pressure, prolonged straining, ascites, and intra-abdominal mass, or pregnancy. 5. Genetics. 6. An absence of valves within the hemorrhoidal veins, and aging. 7. Obesity, prolonged sitting. 8. Chronic cough. 9. Pelvic floor dysfunction. 10. Squatting while defecating may also increase the risk of severe hemorrhoids. 11. During pregnancy, pressure from the fetus on the abdomen and hormonal changes cause the hemorrhoidal vessels to enlarge. The birth of the baby also leads to increased intra-abdominal pressures. Pregnant women rarely need surgical treatment, as symptoms usually resolve after delivery. Pathophysiology. There are 3 main cushions present in the normal anal canal. These are located classically at left lateral, right anterior, and right posterior positions. They are composed of neither arteries nor veins, but blood vessels called 1. Sinusoids. 2. Connective tissue, 3. Smooth muscle. 1. Sinusoids do not have muscle tissue in their walls, as veins do. This set of blood vessels is known as the hemorrhoidal plexus. Hemorrhoid cushions are important for continence. They contribute to 15 to 20% of anal closure pressure at rest and protect the internal and external anal sphincter muscles during the passage of stool. When a person bears down, the intra-abdominal pressure grows, and hemorrhoid cushions increase in size, helping maintain anal closure. Hemorrhoid symptoms are believed to result when these vascular structures slide downwards or when venous pressure is excessively increased. Increased internal and external anal sphincter pressure may also be involved in hemorrhoid symptoms. 2 types of hemorrhoids occur, 1. Internals from the superior hemorrhoidal plexus, 2. Externals from the inferior hemorrhoidal plexus. The pectinate line divides the 2 regions. Diagnosis of hemorrhoids. Hemorrhoids are typically diagnosed by physical examination. 1. A visual examination of the anus and surrounding area may diagnose external or prolapsed hemorrhoids. 2. A rectal exam may be performed to detect possible rectal tumors, polyps, an enlarged prostate, or abscesses. 3. This examination may not be possible without appropriate sedation because of pain, although most internal hemorrhoids are not associated with pain. 4. Visual confirmation of internal hemorrhoids may require anoscopy, insertion of a hollow tube device with a light attached at one end. 5. The two types of hemorrhoids are external and internal. These are differentiated by their position with respect to the pectinate line. Some persons may concurrently have symptomatic versions of both. 6. If pain is present, the condition is more likely to be an anal fissure or an external hemorrhoid rather than an internal hemorrhoid. 7. External hemorrhoids occur below the dentate, or pectinate, line. They are covered proximally by anoderm and distally by skin, both of which are sensitive to pain and temperature. Diagnosis of internal hemorrhoids. Internal hemorrhoids originate above the pectinate line. They are covered by columnar epithelium, which lacks pain receptors. They were classified in 1985 into 4 grades based on the degree of prolapse. Grade I, no prolapse, just prominent blood vessels. Grade 2, prolapse upon bearing down, but spontaneous reduction. Grade 3, prolapse upon bearing down requiring manual reduction. Grade 4, prolapse with inability to be manually reduced. Differential diagnoses of hemorrhoids, many anorectal problems, including 1. Fissures, 2. Fistulae, abscesses, 3. Colorectal cancer, 4. Rectal varices, 5. Itching. 6. Rectal bleeding may also occur owing to colorectal cancer. 7. Colitis including inflammatory bowel disease, diverticular disease, and angiodysplasia. 8. If anemia is present, other potential causes should be considered. Other conditions that produce an anal mass include 1. Skin tags, 2. Anal warts, 3. Rectal prolapse, 4. Polyps, 5. Enlarged anal papillae, 9. Anorectal varices due to increased portal hypertension. Blood pressure in the portal venous system may present similar to hemorrhoids but are a different condition. Prevention of hemorrhoids. A number of preventative measures are recommended, including 1. Avoiding straining while attempting to defecate, 2. Avoiding constipation and diarrhea either by a. Eating a high-fiber diet, b. Drinking plenty of fluid or by taking fiber supplements, c. Getting sufficient exercise, 3. Spending less time attempting to defecate, 4. Avoiding reading while on the toilet, 5. Losing weight for overweight persons and avoiding heavy lifting are also recommended. Management of hemorrhoids. 1. Conservative treatment typically consists of 1. Foods rich in dietary fiber, 2. Intake of oral fluids to maintain hydration, 3. Nonsteroidal anti-inflammatory drugs, 4. Sitz baths, 5. Rest. 1. Increased fiber intake has been shown to improve outcomes and may be achieved by dietary alterations or the consumption of fiber supplements. 2. Evidence for benefits from sitz baths during any point in treatment, however, is lacking. 3. If they are used, they should be limited to 15 minutes at a time. 4. Decreasing time spent on the toilet and not straining is also recommended. 5. While many topical agents and suppositories are available for the treatment of hemorrhoids, little evidence supports their use. 6. Steroid-containing agents should not be used for more than 14 days, as they may cause thinning of the skin. Most agents include a combination of active ingredients. These may include a barrier cream such as 1. Petroleum jelly or zinc oxide, 2. An analgesic agent such as lidocaine, 3. A vasoconstrictor such as epinephrine, 4. Some contain balsam of Peru to which certain people may be allergic. 5. Flavonoids are of questionable benefit, with potential side effects. 6. Symptoms usually resolve following pregnancy, thus active treatment is often delayed until after delivery. Evidence does not support the use of traditional Chinese herbal treatment. 7. Phlebotomics in the treatment of the symptoms of hemorrhoids grade I to II, although these drugs are not approved in the United States as of 2013 and in Germany, and restricted in Spain for the treatment of chronic venous diseases. Procedures for treatment of hemorrhoids. 1 rubber band ligation is typically recommended as the first-line treatment in those with grade I to III disease. It is a procedure in which elastic bands are applied onto an internal hemorrhoid at least 1 cm above the pectinate line to cut off its blood supply. Within 5 to 7 days, the withered hemorrhoid falls off. If the band is placed too close to the pectinate line, intense pain results immediately afterwards. Cure rate has been found to be about 87% with a complication rate of up to 3%. 3. Sclerotherapy involves the injection of a sclerosing agent, such as phenol, into the hemorrhoid. This causes the vein walls to collapse and the hemorrhoids to shrivel up. The success rate 4 years after treatment is about 70%. 4. A number of cauterization methods have been shown to be effective for hemorrhoids, but are usually used only when other methods fail. 5. This procedure can be done using electrocautery, infrared radiation, laser surgery, or cryosurgery. Infrared cauterization may be an option for grade I or II disease. In those with grade 3 or 4 disease, reoccurrence rates are high. Surgery treatment of hemorrhoid. All surgical treatments are associated with some degree of complications including 1. Bleeding, 2. Infection, 3. Anal strictures, 4. Urinary retention, due to the close proximity of the rectum to the nerves that supply the bladder. 5. Also, a small risk of fecal incontinence occurs, particularly of liquid, with rates reported between 0% and 28%. 6. Mucosal ectropion is another condition which may occur after hemorrhoidectomy, often together with anal stenosis. This is where the anal mucosa becomes everted from the anus, similar to a very mild form of rectal prolapse. 1. Excisional hemorrhoidectomy is a surgical excision of the hemorrhoid used primarily only in severe cases. It is associated with significant postoperative pain and usually requires 2 to 4 weeks for recovery. However, the long-term benefit is greater in those with grade 3 hemorrhoids as compared to rubber band ligation. It is the recommended treatment in those with a thrombosed external hemorrhoid if carried out within 24 to 72 hours. Glyceryl trinitrate ointment after the procedure helps both with pain and with healing. 2. Doppler-guided, transanal hemorrhoidal dearterization is a minimally invasive treatment using an ultrasound Doppler to accurately locate the arterial blood inflow. These arteries are then tied off and the prolapsed tissue is sutured back to its normal position. It has a slightly higher recurrence rate, but fewer complications compared to a hemorrhoidectomy. 3. Stapled hemorrhoidectomy, also known as stapled hemorrhoidopexy, involves the removal of much of the abnormally enlarged hemorrhoidal tissue, followed by a repositioning of the remaining hemorrhoidal tissue back to its normal anatomical position. It is generally less painful and is associated with faster healing compared to complete removal of hemorrhoids. However, the chance of symptomatic hemorrhoids returning is greater than for conventional hemorrhoidectomy, so it is typically recommended only for grade 2 or 3 disease.